So if it's estrogen only, then that is theoretically, at least in many people, suppressing endogenous testosterone. So it's really comparing testosterone to inhibiting testosterone.
So now we move over to testosterone in women. And this was a study in postmenopausal women who also began HRT at the same time. So some form of systemic estradiol, I believe. And they were taking an oral testosterone preparation, a
oral
proprietary one.
Yeah.
So not anything that is commercially available, but it was a 40 milligram dose, which is substantially lower than what's out there commercially now. They're taking it twice per week. And it was effective. They had improvements above and beyond what the estrogen-only group had. But take a look at those adverse effects there.
Yeah, so very interesting.
Remember here, placebo is estrogen only.
So if it's estrogen only, then that is theoretically, at least in many people, suppressing endogenous testosterone. So it's really comparing testosterone to inhibiting testosterone, especially free androgens. Estrogen will greatly decrease your free androgen index by increasing SHBG. Mostly so if it's oral, but because of first pass, but in general it will. But anyway, they looked at acne and about 15 to 17%, 17% in the testosterone group. Again, 35 individuals in both groups, so not a huge study.
Yeah,
but
and not
big
statistically significant.
Yeah, so scientists can not listen. This is probably clinically significant, though, at least the lack of difference. 17% in testosterone, 14% in placebo, p-value 0.1. With hirsutism, which is unwanted hair growth, 8.8% versus 8.5%. So what this tells me is if you decrease your testosterone, you will grow you'll grow beard 8% of the time, and you'll get acne 14% of the time.
Yeah, it was really interesting to me because presumably women didn't know if they were in the placebo or testosterone group. So women, they're not stupid. They know what testosterone is. So they started in this trial taking their testosterone or placebo and checking for these things. And they realized, oh, I do have some hairs on my chin, or, oh, I am getting an odd pimple here or there. So estrogen is not causing women to grow beards. But even if you look at placebo group and like Turner syndrome, for example, about 6% of those in placebo group are saying, yes, this medication caused me to virilize, when they did not actually get oxandrolone. They were getting the placebo for their acceleration of growth. So 8% of women, I wouldn't be surprised if it was over 10% cumulatively over the lifetime, are going to have some signs of hirsutism just by nature of their androgen sensitivity or their own androgen production.
Or their insulin resistance and low SHBG at baseline.
Yeah, probably now more than if we went back 20, 30 years ago. People who became more insulin resistant.
We mentioned testosterone patches, and some people might be familiar with these in men, but you can also give them to women. And props to the people who studied the patch. The dosage is pretty interesting in this chart. If we paste this in, yes, it says grams per day, but it was definitely not 300 grams per day. It was 300 micrograms per day.
Much more reasonable dose.
Something like a 0.3 or a 0.45 milligram dose. And they looked at a lot of adverse effects. And yes, for some of them, you do see a dose-dependent effect. They also looked at levels of both testosterone and DHT. And I think they used equilibrium dialysis to measure those.
Yeah, for the free hormones, yes. The thing here that was striking to me, but makes sense with as many testosterone levels as I've seen on people using transdermal products, is that the DHT was quite high. So the highest the total testosterone levels approached was just north of 100. I think it was around 115 in the highest dose group. But they had a DHT level of 30. And you would tend to expect about a 5 to 10% conversion, probably slightly on the higher end of that for women from their natural production. Certain things like insulin resistance can accelerate that. There's medications that can reduce that conversion rate. But whenever you're applying testosterone to the skin, you get a disproportionately higher amount of DHT. So This would tend to be less sustainable in my mind as an option for improving libido, but a great option as a sort of test drive is how I talk to it, because you don't want to go get a testosterone pellet put in and then find out that, oh, this isn't a good fit for me, and now you have to ride it out for 3 or 4 months. Testosterone cream can be a nice way to see, dip your toes in the water and see, do you have any adverse effects? Are you a good candidate for you? Are you even a responder to it? Because again, not 100% of women are going to respond to testosterone in terms of improving libido or sexual function.
Yeah, low barrier to entry. So pretty easy. They don't do an injection training. They don't have to spend a whole bunch of money getting a pellet just because they think it might work. Another decent population would be women who happen to be or happen to need to be on dutasteride for another reason, because that'll obviously inhibit some of the conversion of DHT. And this is for both men and women, the dermal conversion, especially if it is in pubic skin. For example, scrotal or labial skin, you'll have an even higher rate of conversion of testosterone to DHT. So you really have to watch for virilization, or in men, excess growth of the prostate, heart tissue, or hair loss.
Yeah, certainly things to consider. And you don't always need to check a DHT level to know these things, but it is nice to see the data when you have the ability to do so.